So today we will be dealing with FMGE questions from surgery which have been asked recently, quite a few days back. Now, as far as the questions are concerned, I would just like to focus on certain things first. So I will be going through some of the questions which I had put in my Platinum Q Bank and NEET PGQR. So first of all, remember this important condition, torsion of testes. So this is a question number 111 from Platinum Q Bank. Now again, question number 55 regarding the management of pneumothorax. I mentioned it over here. Then third is a question I had stressed in as the omphalocele. So the diagram is over here. In addition to that, have a look at this diagram, and this shows hydronephrosis. Then in addition to this, this is a diagram showing tension pneumothorax. So that's important. Now, in addition to that, you can see this condition. This is the specimen of a operated colon, and you can see multiple polyps in the colon, and something like Pure-Jogger syndrome, which I have highlighted over here. Then over here, there is a question I had mentioned, Gastrinoma. Then there is something like epidural hematoma. Now, coming to the questions which were asked directly. So there was first question which was asked, basically a question from anatomy and put in surgery, and breast cancer with dimpling of skin. So there is dimpling of the skin, and it was said which is the ligament which is responsible for dimpling of skin. So as far as the dimpling of skin is concerned, you are well aware of the ligaments of Cooper. So ligaments of Cooper, I think that it is the first basic question which we read once we read the upper limb, and in the upper limb we have got this important topic, the breast, and in the breast we read about certain things like the axillary tail of Spence, which you have to remember, like the foramen of Langer, and therein we come across lake of Styles, as well as certain terms which are very, very important, like the Cooper's ligament. So Cooper's ligaments are basically the ligaments which get infiltrated by cancer cells, and they cause dimpling of skin. So you have to remember this question was asked and multiple ligaments were given. So dimpling of skin in breast CA is as a result of Cooper's ligament. To add a point over here, you have to remember the lymphatic drainage of the breast, the metastatic pathways from which the breast cancer goes in relation to other parts of the body, the bloomer shells. So these are some of the important things you have to remember from a surgical perspective as far as the breast is concerned. Now, image-based question was given in which patient presented with tumor of the left lobe of the liver, and as far as the left lobe of the liver is concerned, there was quinoid segments, you have to remember, and it was said that the patient had to be done with left hepatectomy. So what's important, you know that this liver, it is a very important abdominal organ, and in the liver you have got the segmentation. The segmentation of the liver is anatomy and surgically quite different, because anatomically there are the ligaments which divide the liver into right and the left lobes, posterior the caudate and the caudate lobes. But the latest classification was suggested quite some long back, but we still call it latest, is the quinoid segmentation of the liver based on the pattern of the ducts and the veins. So in that we have got these 8 classic segments but you have to remember this quinoid segment, the orientation of the quinoid segments in the right and the left lobe of the liver. So that's a question which was posed. So basically, if you have a strong anatomy, you have got good chances of doing surgery well in your exams. So that's important. Then there was an ulcer which was shown, and the ulcer at the site of the lower limb showing signs of irregular edges, pigmentation, and shallow base. So basically you have to remember some of the pathological features of some surgical conditions, and that is very important. So venous ulcers, you have to differentiate between various types of ulcers. The pressure sores, you have to differentiate between decubitus ulcers, the venous ulcers, and multiple other conditions which affect the skin. So as far as this venous ulcer is concerned, you have to remember that it has a shallow base, it might be pigmented, these edges are irregular and usually present within the vicinity of the lower limb at usually the pressure sites. So that is very, very important. Now, as far as one of the questions is concerned, it was a simple interrupted suture. I think that you know what is the difference, what are the different types of sutures. A very simple question, IBQ based. And then there was this question about the varicose veins, which has been dealt with in anatomy. So there was this varicosity along the territory of the great saphenous vein, and you have to remember the venous drainage of the lower limb. In the lower limb there are certain important questions which are important from a surgical anatomical viewpoint, and they are the arches of the foot, they are the venous drainage of the foot. In orthopedics they are the cruciate and the trochanteric anastomosis, fracture neck of femur, and you cannot afford to miss those questions, very high yield questions. Now there was a question, a patient with gastroesophageal reflux disorder has a nodule in the second part of duodenum, and basically there was something that in the history it was mentioned that the question was not clear as yet, but some students told me that the question had got recurrent epigastric pain, not responding to conventional proton pump inhibitors. It was like that. So a clue, so which physiological substance would be increased? So you have to remember to this important condition, which I will deal in detail at the end. So here I am giving just a gist of the things which were asked. So you have to remember that this clinical condition, gastrinoma, is concerned with hypersecretion of gastrin, which is an important physiological substance. And as far as these tumors are concerned, gastrinoma, glycogonoma, somatostatinoma, insulinoma, and multiple other rarer entities. But you have to remember the characteristic features of these clinical oncological entities, and insulinoma and glycogonoma and gastrinoma happen to be examiner's favorite as far as pathology is concerned, as far as surgery is concerned. Then a 2-year-old child, an exact clinical scenario was given. A 2-year-old child has a scrotal swelling since birth, and sometimes he's having one pain. He's suffering from painful swelling, which has gone. The swelling has become painful, it has become red, and it has become irreducible. So what is the clinical condition? So basically, once somebody presents with something outpouching of a organ, and that's called as classically hernia, and hernias can be reducible, hernias can be irreducible, hernias can get strangulated, and once they present with pain, redness, and increased tenderness, at that point of time that we call that hernia as a strangulated hernia. So strangulated hernia, you have to remember the features of a reducible, irreducible, and strangulated hernia, whether the hernia is femoral, whether the hernia is inguinal, or of any other category. So that's very important. Now this was a question asked. Then there was a question based on burns, and the child presented with massive burns. He was dehydrated, and as far as 20% burns, which is a significant, major burn, and low urine output. So urine output was low after 6 hours, and he had cool extremities. That means he might be going into a state of shock. So what would you give? So the first thing is that wait and watch. No, that can't be a policy. Number second, so conservative approach is not there. You need to have a contingency emergency plan for treating a burn patient. And the first and the foremost important thing is that you give him a fluid in the form of a massive bolus, big bolus of fluid. So that was a question based on simple management of emergencies, and I don't think it was a question which needed much. It could have been solved from a basic concept viewpoint. So how to deal, you should remember the priorities of treating different clinical conditions. So in here the patient is having dehydration, the patient is having a low urine output, he might be going into a state of shock. So the first thing you do is to treat him with, there were some options given but they were not relevant. So the first thing was to rehydrate him back. Then a patient had gone a lap cholecystectomy 4 days back, and now this is important, cholecystectomy, and then 4 days back, and now complaining of right upper quadrant pain. So cholecystectomy itself presents with right upper quadrant pain, and then in case there is this patient who presents with same things even after cholecystectomy, and USG shows a collection within this area, the area where from the gallbladder was removed. So there is a bit of a collection over there. So next step would be the post. So this the diagnosis is the post cholecystectomy syndrome or the post cholecystectomy, which can be having pain as well. And the first thing, because there's a collection, so you do ultrasound guided drainage. You do not wait. There's a collection. It is an established collection post cholecystectomy. So you do not allow the septic focus to be there. So you remove the USG, this collection through a procedure which is simple, which is not much manipulative, because he has undergone a surgery just a few days back. And then, so the best modality would be USG guided drainage. Now, there was a question of basically a chylomlymphatic cyst, and this should not have been a UG question from my perspective. So what's the treatment of a patient who is diagnosed with 8 to 9 centimeters chylomlymphatic cyst? So you have to remember these cystic entities, whether it is the cystic hygroma, whether it is the mesenteric cysts, or whether it is the chylomlymphatic cyst, or it is the hydrated cyst. So you are aware of Pear technique, which is followed in case of hydrated cyst. You are aware of enucleation. You are aware of marsupialization. So over here for a chylomlymphatic cyst, the best modality of treatment would be enucleation. So enucleation was the correct answer. Extradural hematoma, image-based question, I will be coming to that as well. Now, then a neonate had a clinical scenario has intestines protruding from the abdominal wall. So there is the intestines protruding from the abdominal wall. The next step. So you are aware of these two clinical conditions, omphalocele and gastroschisis. Omphalocele presents without a covering. You are aware of that. But here the question is not just diagnose the omphalocele or umbilical hernia or gastroschisis. It is simply omphalocele, and you have to remember what's the best next step. So you just cover him with silo and wait. So that's important. I mean, it's not the ultimate thing which we do, but it is the next step. So you have to see, you have to go and fix your concentration towards what the examiner is asking, whether it is the treatment of choice, whether it is the next step, or it is not the treatment of choice over here. It is next step. There's a large gap between these two things. So next step, important. So you may be knowing a lot, but here you have to focus what the examiner is asking you, not what you know. So many students fall in this trap or giving the best option, but it is not the best option over here. So that you have to remember. That's why some of the students get it very wrong. So that's it. Image-based question, umbilical hernia. I had given in my book an image of an umbilical hernia, in which it is simply, because you know hernia, I mentioned it, protrusion, and then at the level of umbilicus, it can be para-umbilical, it can be supra-umbilical, infra-umbilical. So you have to differentiate these from the divercation of the recta and multiple other conditions. I will not go into that, but simply recognizing an umbilical hernia, you know the importance of the umbilicus as far as the watershed line is concerned, as well as the umbilical adenoma is concerned, which was also asked recently, and as far as the urachus is concerned, you can have the umbilicus is very important. I have many surgeons do not recognize the importance of umbilicus, and I would tell you here that umbilicus is very important. Watershed line, embryologically. Number 2, umbilical adenoma. Number 3, which is also given the name as cherry red tumor, asked. Number 3, the umbilical lymphatics here divide up and down. Caput medusae at the level of umbilicus. You have to remember the pattern of the veins in the umbilicus. Then you have to remember omphalites, which can be an infective condition affecting the umbilicus. Then you can be having discharge of fecal matter, persistent or vital intestinal duct, discharge of urine through the persistent urachus, and sometimes some very important phenomena, vicarious menstruation, in which a female might be presenting with bleeding through the umbilicus, along with the hemoptysis, as well as during the menstrual periods. So that's a very rare condition though, but you have to remember these conditions. And the T10 segment supplying the umbilicus, which is asked in case of referral pains of the umbilicus. So that's important. So that's important. Now, the next question asked was a 14-year-old with acute testicular pain and cremastic reflex. Next step would be, so you are well aware that sometimes you can have a pain in the testicular region, the testes would be tender, the patient might turn febrile, and then this is a surgical emergency. The options are limited. You have to recognize, you have to be a good physician, a good surgeon to recognize this condition, and the next best step would be the exploration of the testes, because this is a condition in which the testes can undergo necrosis. Torsion can cause interruption of the blood supply of the testes, the testicular arteries. There is the papillary plexus of veins over there. There will be congestion within the testes. The testes will undergo gangrene, necrosis, and testes can't be recovered back. It will be too late, and you have to be very vigilant, and you have to have a high level of suspicion and be very, very agile and aggressive in treating this. Exploration of the testes is the step you have to follow. Important, not yourself, but you have to, in case you're not a surgeon, match your surgeon. So the exploration of it is not mentioned there. It's the next best step would be. So it is that. Now, after maxillary facial trauma, a patient cannot, you cannot intubate or ventilate. The immediate steps are, so here, you know that in the anterior middle line of the neck, there is the cricothyroid membrane, and once you pierce the cricothyroid membrane, you open an outlet, I would say inlet for an alternative pathway. So in case of a maxillofacial trauma, so this is very important, one cannot intubate or ventilate. The immediate step, because the patient will be in a state of distress, so you just pierce the cricothyroid membrane through an appropriate instrument, and that will relieve the patient of the distress which he or she might be having. It's an important procedure and sometimes turns out to be a life-saving procedure. So you have to remember not to be attempted by inexperienced people though. Remember. Then this question was already discussed in pathology. A patient presents with multiple polyps along the gastrointestinal tract, along with the pigmentation of the mucosa, oral mucosa, and you are well aware of this thing, the hamartomatous polyps, the Pearce-Jogger syndrome. So I will not go into the various surgical conditions, the FAP, the HNPCC, the Gardner syndrome, the Turcot syndrome, and multiple other syndromic entities associated with polyposis colon. But this is a very important question, repeated. So Pearce-Jogger syndrome, that's very important. You cannot miss it. Now, there was a patient who had a trauma, penetrating chest trauma with tracheal deviation, unable to breathe, in respiratory distress. So next step of management would be, so again, it's not a best treatment modality. The next step would be needle decompression. So you just insert a needle with the intercostal space and you do a needle decompression, and that relieves the patient of his respiratory distress. So the question was basically open pneumothorax, and you have to be very vigilant in diagnosing this condition as well. So just on the basis of the severity of the symptoms, and there needs to be a rapid exploration of this thing. So the needle would be inserted and that will relieve pressure, followed by ICD as well. A question was given about diverticulum from the ureter, uretrocele. So you should be well aware of these clinical entities, cystocele, uretrocele, how they present in the images, and so that was an image-based question. So again, I repeat this, open pneumothorax. So the step is needle insertion followed by intercostal chest tube drainage. Then there was a question there about which there was a bit of a confusion whether it was a EDH, extradural hematoma, or diffuse external injury. So over here, the patient had a severe head injury, poor Glasgow Coma scale, normal CT, and he died within few hours of the injury. So if this was the case scenario, then I think the axonal injury, diffuse axonal injury, is the most likely statement which can be made. But overall, I am not well aware of what the exact question was, but you have to remember the difference between SDH, EDH, intracranial hemorrhage, and subarachnoid hemorrhage. So I will be coming to that as well. And there was a image which I will be coming up about the hydronephrosis. So from I think neurosurgery, nephrosurgery, there were some important clinical based questions. So you have to be, I mean to say, have an expertise in all aspects of surgery, whether it is neurosurgery or it is other aspects of surgery. Now going back, so I will just be winding it up with having a look at the things, how I had already predicted these things. So question number 111. So we went through the questions, and this sudden, I will just go for making it more palatable you so that the future students also understand these things. I had mentioned sudden onset of severe pain, marked swelling of the scrotum, high fever, testes is intensely tender and edematous. So the options were massage the testes. No, we have not opened up a massage center, but over here the important thing is that orchidectomy is the next. So testicular torsion is, I mentioned it, what I mentioned in the, so wait and watch. No, you do not expect orchidectomy. You go for immediate surgical exploration, alternatively what I have been telling you. Patient with trauma, severe chest pain, respiratory distress, tachypnea, collapse. In the question it was also mentioned the tracheal deviation, and the next best step is best initial management. So over here is the thing which I was mentioning. Arterial blood gas analysis that will not serve any purpose. Ventilation perfusion scan, it don't have VP scans at every place. So, and it is for pulmonary embolism, which can be a possibility though. Pericardiocenticity will not serve any purpose, so that's it. So this diagram you have to remember. So this is an omphalocele. So this is an omphalocele, and you know the management, just I mentioned. So I had mentioned this thing as well. So a question which I told you that this is hydronephrosis. So you see the kidney. So you see the kidney area. It is enlarged, and there is the blunting of the calyces, and you can see this kidney is very enlarged in comparison to this kidney. So this is small kidney. Compare the sizes. So over here, so this is the hydronephrotic kidney. I mentioned it. So over here you have to remember this is the hydronephrotic kidney. The huge size, flank pain, chest pain and dyspnea. So you can see that this is the area in which you can see that this is the area of the pneumothorax, completely dark blackish. So here the lung shadow is not that blackish, more lungs, more black. You have to remember pneumothorax in that concept. So more black, more air within the lungs. So this is the area of the pneumothorax. Now I was mentioning Peter-Jogger syndrome. Here is an image which shows these polyps within the colonic mucosa, carpeted by multiple polyps, and the pigmentation of the oral mucosa. That's so Peter-Joggers. Now gastrinoma, I have mentioned it in full detail, a question over here. So you can be seeing central abdominal pain, attacks, frequent, multiple. There's no history of anything which causes an ulceration. Endoscopy relieves what he has mentioned. He had mentioned duodenum. I have mentioned it, antrum, duodenum, jejunum, and important. H. pylori is not is negative. So this is the way questions are asked in USMLE, and you have to have a concept. So this is gastrinoma, multiple attacks, and endoscopy relieving. And what is increased is the gastro. Epidural hematoma, I mentioned you, so you have to remember this image. So this image, this is the CT scan of a patient who presents with epidural hematoma, and you know the epidural space or the extradural space, and herein there is the rupture of the middle meningeal artery, which lies at the level of the pterion. I will not go much detail, I will deal with it, and I have dealt it within anatomy, so not over here. So this is something which you have to remember, and out of this thing you are aware of these things to which I am pointing the pointer: platinum cubing, volume 1, volume 2, and image-based platinum cubing, in addition to something like the NEET PGQR. So this is a book which was there and from which students revise, and these are the I guess the 90% books, what they call them, because almost 90% of the questions were from these books. So I feel pretty glad, pretty happy that students benefited by reading my books, and many of the students just express their, I mean to say, desire to just propagate the book for future students as well. And they were very much overwhelmed with the number of questions asked from this book. So I would be very happy. At the end of the class, I would be very happy to see the smile on the students' faces, and that's what is representative of a good teacher. Thanks a lot.